Welcome to this episode of Doctor Patient Conversations on a very important topic of diagnostic safety. We have with us today a very renowned internal medicine, what we call a general physician, of 50 years of experience in various fields, various diseases, and a very gentle and a very experienced doctor who will advise us on the path we should take for early diagnosis to prevent errors. He has been a teacher in medical colleges, he has been with embassies, and also a practicing physician in Gangaram Hospital for several years. Welcome and thank you, Dr. Hazuria,
Thank
for
you.
being with us today. Today, our topic is on diagnostic errors. The journey, as we see, of any medical health or treatment begins with this engine of uh, early diagnosis, and we often blame the doctors or we often have regrets that we could have done something. Please tell us what are the kinds of errors and who's responsible for such errors.
See, the diagnostic errors normally can be subdivided into a couple of categories, and they can be due to missed diagnosis, wrong diagnosis, or delayed diagnosis. Only these three things can cause diagnostic errors, resulting in improper, unexpected care to the patient. And the causes can be either with the doctor, with the paramedics, with the laboratory diagnosis, or with the patient himself. Certain things which the patients are also to be blamed for not helping us to reach the correct diagnosis.
Thank you, Doctor. I bring to everybody the voice of patients from Patients for Patient Safety Foundation. And I have with me several questions collected from friends, family, and experiences by patients. The very first one is how much harm and what is the nature of harm if a diagnosis is not done properly in time? Does it happen in hospitals or does it happen only at home?
No, this can happen anywhere in the OPD, in the inpatients, or at home. See, in US, they say nearly one third of patients who die can be because of diagnostic error, not because of doctor only. Doctor, wrong diagnosis, wrong laboratory investigation, and lastly the patient's fault. And in OPD, about 5 to 50% diagnosis missed. In the inpatient hospital, about 17%, up to 17% diagnosis can be missed. And for the patient's own fault, again about 15 to 20% diagnosis can be missed if your patient doesn't give the proper information or he comes very delayed for the reasons, any reason what he has.
So, what you're saying is there is a role that a patient has and there's a role that a doctor has. So, what is the process that you follow as a physician to find out the exact diagnosis?
See, the exact diagnosis starts with taking patient history. And we are probably a little old school of thought, and we feel that 70% of the diagnosis can be made just by a proper patient history, present history, past history, family history. So all these things can reach us to diagnose. So about 30% we need some more investigation, and out of them another 5% for super investigations like MRI and other things. So basically, it starts with us taking a very proper history of the all parameters I've told you, personal, family, past history, and then come the investigations, relevant investigations.
So, it's a triangle of stakeholders.
Yeah.
So, if I
Yeah.
begin with the very first stakeholder, which means a family or a patient, how do I know that I'm sick? How do I know that I'm potentially ill? Are there certain symptoms or red flags, as you call it, that I should watch out for to present myself early?
See, there are a lot of red flag symptoms which can patient can take you to a doctor, which should rather you should go to a doctor. See, like you have a swelling in the body, in the neck, anywhere in the body, which is unexplained. It is painless swelling. So that can be a serious thing. It can be simple cyst or it can be a cancer also. Like you have lot of urine passing, lot of appetite is there, and you're still losing weight instead of eating so much. That could be early sign of diabetes. Same way, you have lethargy, chronic headaches. That can be sign of blood pressure. So especially these are very relevant if there is a family history of these things. If there is a family history of diabetes, high blood pressure, cancer, then we have to be very careful about these even mild symptoms. like even cardiac illness. There's family history of young cardiac death in the family. Your parents had cardiac illness before the age of 50 or 40 years in females and 50 years in males. Then you have to be careful of any symptoms, like you get breathless on short walking, climbing stairs. You have some discomfort in the chest. You put it onto gas. You know, a lot we see every day. "No, this is a little gastric only.
Right.
I passed gas and I felt better." But that's a very unusual diagnosis. So that has to be looked into. You should see a doctor for not an occasional thing, but when you think that it's not settling down and it's recurrent and you're not comfortable with it.
So, which means there are certain symptoms, whether it's fever or continued pain, or we don't understand why the pain or why the lumps are there, we must go and see the doctor. But sometimes we try to brush it aside. Our first natural instinct is, let's do something at home. I mean, I know a friend who had diarrhea as well as constipation, and they kept on changing food habits or water habits until it was very, very late that they realized it was colorectal cancer. So, is there any kind of a test or anything that could be done to find it early or to spot it early? Or how do we choose a doctor in the first place? How do I go? Do I go to a GI or do I go to a medicine? There are so many such few GPs now.
See, one should go to internal medicine, physician only to begin with, because we see a lot of people having a sore throat. They go, especially, and cough and all, go to a ENT specialist, whereas the problem lies in the lungs. He may be asthmatic or something. So same way, you should follow your identify a good physician, general physician or a MD physician, and go through him and tell him probably your symptoms in detail and see. And family is very important. Again, you said colorectal cancer. Even that can be familiar. Breast cancer can be familiar. Prostate cancer can be familiar. So these are the common cancer which can pancreatic cancer. They can be genetic in nature. So I think physician is the best, and he's like a postman. He'll see your symptoms, see if you can handle it, or get investigated, or refer you to a proper, say, gastroenterologist or a chest specialist or a cancer specialist, depending on what's required. So he is the best person to screen you and do basic investigation, then take further action.
That's a very nice thing you've told us, because in this modern day we all end up going to specialists and maybe even super specialists. I mean, I know another case that went to a particular organ. I mean, it could be a dentist, it could be an eye, and the treatment went on and on, but the symptoms didn't go, and he was at the end of the road before they realized that it was something else. What do you do in such cases when you go to a specialist and yet the treatment is not satisfactory?
See, you should always, after seeing a specialist, go back to your physician and let him analyze and follow you up, because specialist is going to see you once in a while. He's not going to see you every week or 10 days. So it's always better to see if you see, number one, you should not see a specialist directly. It's whatever symptom. I told you the example of
Right. It has to be recommended by somebody. That means
So
there is
go
a
to
second
a
stage.
family physician, and second stage is go to a specialist. If you feel that your general physician or a medical specialist is not able to convince you or handle you in the next few days, your symptoms don't go, you can even ask him, can I see another specialist? Which we don't mind, which we physicians don't mind.
So taking a second opinion
Second
is not
opinion is not
offending to
this. No,
to
it's
a real
not at
doctor,
all.
but
Yeah,
we're
no,
always afraid of doing that. We are
no,
always afraid to ask questions,
no.
actually.
You're afraid to lose a patient, but no, it's always benefits the doctor also,
Right.
and helps him to improve his practice, or not to hold on to a patient. So
True.
that's fine. Yeah, I don't think anybody physician will mind that. Yeah.
And you mentioned 30%, 70% is clinical, or the doctor and the patient conversing or interacting. But of late, one hears that physicians depend on tests to 70% to take a decision, and barely 10 or 15% is actual clinical examination, which is, maybe it's an overload, maybe there's overload of technology. I don't know what is there, but how do we navigate that percentages or that space?
Yeah.
What are the kind of tests that we must do?
See,
What are the
this is,
categories?
yeah, as I said, the history is very important. All your further investigations are dependent on your history. What does it lead to? Does it lead to a cancer? There are only three things: cancer, some infection in the body, or vascular. Vascular means your heart issues, blood pressure, or something in the brain. Sometimes you have vertigo and all this thing. So then he narrows down his diagnosis. You may not be able to make a diagnosis in the first consultation. So you have 1, 2, 3, and then accordingly he goes. So uh, time spent on a history is worthwhile, which of course is getting rarer because of the overload of patients and loss of patience on the part of doctors also.
So you
And
mentioned three categories. You mentioned vascular, you mentioned cancers, and you mentioned infections.
infections. Yeah.
Right. So these are the three things that we should definitely therefore partner with. If I have to take responsibility, equal partnership,
Yeah,
and we must watch out for these. And what are the tests to match these? What are the kind of tests that you have? You mentioned tests as well.
Yeah. See, if you suspecting a cancer, then of course you have to go for a either a CT scan or a MRI, or suspecting a colorectal cancer, go for a barium enema or colonoscopy. Depends on what are you suspecting. But this second degree of tests are, first is some blood tests. Some cancer markers can also help you diagnosis,
Right.
like prostate cancer, PSA. For pancreatic cancer, we have some tests, CA125, other tests, which can lead you to a diagnosis, but not a definite diagnosis.
Right.
Definite diagnosis only by MRI and other investigation and by biopsy, followed by a biopsy. That's the only way to have a definite diagnosis, because no oncologist will start a treatment without a pathological diagnosis. So similarly, vascular in the heart, as I gave you example earlier, patient has little chest pain which you ignore as gastric or something, and especially if you have young family history of having a cardiac issues, and then you must get a proper cardiac evaluation done. So similar way, neurological problems, you're unstable or you have giddiness at times, you have a history of fainting, short fainting, couple of seconds, they can be something serious also. Maybe something as minor as sudden fall in blood pressure, hypotension, or something in the ears, vertigo, but it can be something more.
Right.
So then in this case, you see a relevant specialist as advised by your physician, and he knows who is the best person in the field and in the city
Right.
who can handle these things.
But doctor, when you said so many tests, as a patient, maybe I cannot afford them, or maybe I have an image that tests are very expensive, and a hospital is just wanting to bill me more and more charges, and my insurance may not cover it. In that case, I may not come back to you. How does one handle that issue of affordability or access to a reasonable test lab?
See, we have to limit our investigations very carefully on the not order unnecessary. Unnecessary means that, see, there's a safe practice going on in the medicine also. You don't want to take any chance.
Right.
If patient says headache, well, you know it's not a something to do with the brain, but you don't want to burn your fingers. You say
True.
no, get an MRI done.
Yes.
So this is also not a good practice. That's why I say the
Like
history.
excess
Yeah,
testing.
excessing of testing.
Whereas basic elimination should have
and
been
it's a
there
lot of
beforehand.
cost on the patient.
Yes.
And which doctors, of course, it's not their headache that what the patient is spending, but there are a lot of people who cannot afford it. And there are labs, or MRI or blood test labs, which are low cost, comparatively low cost, and yet authentic.
Right.
And last alternative is that you go to a government hospital.
Yes.
Even there, the MRIs are not free, and there's a waiting list for a couple of months before you get a thing done.
By then, the disease would progress.
Disease will progress. Otherwise, in private
That is
and
the
all,
hindrance.
you can get the same day test done, and by evening you have the
True,
report
true.
ready. So this is unfortunate that this is everywhere, not even in India, abroad also. People
Right.
have to wait for months to get even simple X-ray done for arthritis or for any other reason.
Right.
So our things are much better here in this kind of our country. That serious patients do get immediate attention, but routine diagnosis may take long time.
Which means, are you saying there's a hierarchy of tests, like you mentioned, pathology, and in my language, it'd be just a blood test. Many things can happen in a blood test, and then I follow by a sonography, and then I go for a radiology or an imaging test. Is there a hierarchy to the tests?
Yeah, I think so. I think that's what we normally follow. See, like do a basic blood chemistry and some cancer tests.
Okay, that's in the first stage.
First stage, if it just leads you somewhere, or clinically you find there's a lump, find the liver or something is in law. First we go for sonography, which is much cheaper. And if that doesn't make you reach the diagnosis, then you go for CT scan or MRI.
Okay.
So these are we always go by that way.
What diseases just the blood test can identify? What are those diseases, and what diseases can the sonography identify?
See, simple diseases like diabetes and high cholesterol level, which lead to heart issues and all that, and then certain cancer, as I said, pancreatic, prostate, lung cancer. There are a lot of parameters on the blood test which can give us a diagnosis of a cancer. So those are the main things which lead to
So in the first stage
in the
itself.
first stage.
And an ultrasound or a sonography, what does that identify further?
So ultrasound will definitely identify a lot of issues. You may have something in the lungs. It might show your prostate issues, or your spleen, or stomach, and all that, but not as clearly as a further investigation.
So this goes into the organs,
Yeah,
at the next level,
next level,
in the tissues, right?
because ultrasonic sonography does not justify anything in the soft tissues like intestine and stomach and all.
Okay,
It only
soft
can
tissue.
pick up, say, gallstones or prostate. It can, which is a solid organ, or liver or spleen. But normally it will not pick up anything happening in the intestines.
That means we may need both.
Yeah.
And that's where we get confused, where you've just done an ultrasound. Why should I do an MRI? Why should I do a CT scan? So that, I mean, we need to know why we should do that.
No, if you can't reach a diagnosis in the initial stages with the blood test and with the ultrasound, I think you have to go further. You have
So
to
it
go
investigates
You have
further,
to investigate further.
deeper tissues.
Yeah.
So there is a difference for each of these tests.
Yeah, there's a justification and requirement for these tests, and patients should be explained as to why we are doing this test and what are the implications, and what if you don't do this test. And to reach a diagnosis, this is essential. Some people say, no, I like to wait, or it's very expensive.
Right.
So just explain to them the options they have. Either going to a government hospital or some private lab, which is more reasonable and yet authentic. So all these options, the treating physician or the specialist has to explain.
Doctor, I think you're one of the patient doctors, because what you just said is like, it's music to my ears, because nobody explains. They just write down, do this, do this, do this, do this. And we don't know whether we should do it, why we should do it, what will happen if we don't do it. And we go there and somebody makes us sign a form, which they so-called consent form. So the communication aspect, what you just brought out, between a doctor and a patient, how valuable is that, and how would you see that happens on both sides? I think communication has to be on both sides.
Communication is very important. It's a partnership. It's a co-product. It's a partnership between patient and doctor. It starts right from the patient's point of view. As I said, he must disclose all his history, present history, what his symptoms are. He should jot down actually before you go to a doctor. These are my present complaints, and what's his past history? What he has been in the, say, he's 50-year-old. In the last 50 years, has he gone any major illness, any surgeries, appendectomy, gallbladder, and any heart issue? Just briefly points, note down and then the family history, which is again very important.
Right.
Any family history of diabetes, blood pressure, cancer, high cholesterol levels.
Right.
So all these 4 or 5 things are very important. Doctor may not have time to ask you all these things. So this is at one go, doctor can know what is your whole background. So this communication is very good for the doctor and for you also, because many times we find that a patient comes and after, not before closing the door, going out of the clinic, he said, "Doctor, I forgot to tell you this thing. I forgot to tell you this thing."
That's a classic scene.
This is a very common thing,
right.
Which, then you've done your whole thing. Doctor has done his all the history and reasonable diagnosis, but this last factor can be important also. So this is what a good patient's biofeedback himself is very important. And communication with the doctor, of course, starts here only, with the patient's history, past history, family history, and present complaint, thoroughly communicating. And doctor's duty is to explain the provisional diagnosis. We don't expect anybody to expect us to make a final diagnosis on the first visit.
Right.
All right, we say, well, this can be possibilities. Sometimes it makes the patient not sure of the doctor. He's not sure what he's talking. He's saying this can happen, this. But you explain to them in a proper thing that this 1 or 2, 3 possibilities I want to rule out. And why I'm doing this test. These following tests are required.
Right.
Kindly get this done. These are essential. And what does it involve? Say if it involves an MRI or something, then you explain to patient. This is a test which will take 2 hours, cost this much.
So you're telling them how to prepare.
You have to prepare the patient for that.
What to expect, setting expectations.
What to expect out of this. Why we are getting it done.
Yes.
Why can't we make a diagnosis without it?
Right.
So all these things have to be explained by the doctor
So that the
also.
diagnosis
He has
is
equal
correct.
responsibility. As I said, has to be a partnership between the doctor and the patient.
Right. Which means as patients, we need to keep our record of our previous tests. You mentioned family history, and maybe what they call now a smartphone. We have to be smart enough to use a smartphone. Even when nowadays I see there is a soft copy available of any reports. So if we keep it in chronological order and show that to the doctor, it might help both the people. And I think not you mentioned another important point, not just the day's work, but the trend, whether it's blood pressure or it is cholesterol, the trend of the markers that are coming up. So that would be our responsibility.
Yeah, we have to make an Excel sheet or
And
simple.
keep track of it
Yeah,
ourselves.
keep a track of it, and even a simple piece of paper, as
So
you said,
download and
writing
keep
on the different dates.
Right.
See your blood sugar. I give them a diary normally.
Okay, so the
And
health diary.
Health
That's
diary.
a lovely idea. That's a
So-
health diary that you can
So
all
health
keep
diary,
one.
which tells them to take the blood pressure as required, as we tell them
The periodicity of it.
periodically, and
Right.
blood sugar fasting after breakfast.
Okay.
So when the patient comes, we know how the trend has been, how
Right.
to adjust
So that helps.
his medication.
True.
And people are getting.
And that's what we should be doing as
Yeah,
patients. I mean,
this
that's our
is
job,
for
our
us to
responsibility.
Yes. And explain to the
communication.
patient, and then tell the patient to do it. So
True.
we give him something ready made, or this is the
A
diary.
template.
You don't have to
Okay.
look for paper.
Okay.
And this you bring
That's
it
a
up.
great idea. We
They
must
can
learn
even
that.
they even can even WhatsApp to the doctor if it is staying far
Sure.
off.
Right.
You can just send the record. This is my fasting sugar, and
Right.
these are my medication. So even they.
So you mentioned WhatsApp, because we see more and more number of people increasing. The doctor's time is burdened with so many things. There's technology, there's research paper, there's symposiums, and there are patients, of course. So do you have an ecosystem that helps you to pre-diagnose or screen something so that your job and your work, your time is saved? Which is the best modalities, or does everybody have a different system?
No, we
Because
all.
it begins there. I mean, what I tell you, what I don't tell you, did I tell the nurse, did I tell you? I'm confused.
No, we all have our own way of working and organizing our practice. So, like I have a digital paper which records everything what I history, test, the investigation, yeah, all in one paper. And this record goes automatically on my mobile, on my iPad, my computer, and also to patient.
So you have it for each patient.
For each patient.
You have all of them,
Yeah.
and we have our individual records.
Yeah.
As
So
noted
this
by you.
record
That's
goes
a
to the
great
patient also.
system. To the patient as well.
So
Okay.
even if the patient loses his prescription, which
Right.
happens very often,
Right.
he tells doctor, you got the record with you.
Yes.
So or they call you up and to recollect, you can just open that and see what he's talking.
That's brilliant.
What information
Absolutely
wow.
brilliant.
So we all have different ways. A lot of doctors do that on a one prescription only. They'll write the relevant, which is very common practice,
Okay.
especially with people who are too busy. On the one prescription, on the left side they write the history, just brief points, the positive investigation,
Right,
and the right side treatment.
Right.
So it all varies with the your way of you practice.
You have mentioned another thing about taking the tests. How do I choose a laboratory? What are the mistakes? What are the errors? What should I be vigilant about when I go to give my test? Because I know, I mean, I can just quote from friends again. I mean, there was in one case, the technician identified a very serious fourth stage cancer, non-Hodgkin or something, lymphoma. And on the other side, there was another test done, and they marked it as a recurrence. But the doctor said it's not possible that you can have a recurrence because I know the overall clinical help, and both were laboratory based. So how does one choose a laboratory?
See, again, it comes back on your doctor, treating doctor. He knows which are good clinics in the laboratories in the city, and whom he can communicate. Even if it's a doubtful result, he can go back to them and recheck.
Right.
So I think basically it should be your physician who should be, or your specialist who is recommending. Right. And he finds the results are doubtful, they always communicate with the lab.
So the communication is not just with the patients, but it's also with the laboratory.
Yeah.
Whether you're doing it for elimination or identification of a disease or just monitoring the disease. So that would help. And does hygiene or does the technician's skill play a role, or the devices, maybe they're not calibrated?
Yeah, that of course they are now very latest automated devices, and you just feed the sample and you get it out. Manual is very less. Calibration is
technology is improving there.
Technology improved, right. But calibration of the equipment, how often they do it, See, there's a role of various organizations like NABH, CAHO,
Okay.
and other organizations come to maintain the quality standards,
Right.
on these
So
organizations.
there are standards,
Yeah, yeah,
and then there are maintenance of standards, and
yeah,
there are audits of standards,
yeah.
which means we should go to a standardized or accredited
Accurate lab. That's
laboratory.
right. Yeah.
And I've also noticed that readings from one place to the other vary. Is that right? Does it vary?
5%, I would say yes.
It does.
If you get a blood sugar of 110 somewhere and the next lab gives you 115 or 105, acceptable.
So it's
5%.
not the person's fault. It's not the technician's fault. It could be the device.
Yeah, device and the standardization.
Right.
So 5% we can accept.
The variation is
Yeah,
there.
but
Which
not
means
more
if
than.
it is for a long-term monitoring of maybe a long illness or a chronic illness, should we go back to just one place, or if it's not convenient, or how do
No,
you
I think
base
it's
that?
better to stick to one lab.
One lab.
So nowadays they always give you a reference of the last 5 tests also.
Oh, that's so the trend is already there.
Trend is
printed
already
in that.
there.
That's
Lot of
an
labs are
additional
doing.
help.
Lot of labs are doing it.
Going back
So
to the
you don't have to
same
carry whole
place.
lot of your prescription,
Right.
lab reports.
True.
So they have
true.
give you last 5
True.
comparison of the last
Right.
with the dates and all that, which is very useful.
And that takes me to another thought. Whenever we go there, we're also again there's a perception, there's a lack of trust, and we say they're going to just ask me to do a preventive health checkup, and they're going to promote it, and they're going to market it. What is the role of these preventive health checkups?
I think it is important. It's not only marketing, and especially people over 40 and females after menopause. It's important to get it done yearly or bi-yearly, depending on the requirement. But people who need it most are with the family history of diabetes, high blood pressure, high cholesterol, or cancer history. For them, it's very important. Now, say in the ladies after menopause, if she gets a bleeding, suddenly after 6 months, 1 year, that's a little concern, So these should not be ignored.
So there are
There are
there's a
certain
risk,
markers,
a certain risk
risk
with either
factors,
a
yeah.
history or a long illness or a certain age. That means there are people at risk in these categories.
And you have, of course, unexplained fever. You have unexplained loss of weight, loss of appetite. All these symptoms are there, which you just ignore. Are you
Right,
having
okay.
a lot of urine passing? Are they polyphagia, increased appetite? So all these symptoms can be sometimes just part taken of the normal routine. And I drink a lot of water, so I pass a lot of urine.
Right.
So all these things, symptoms have to be. See, you'll be surprised that 80% of the high blood pressure patients are diagnosed only on routine doctor's visit, or during insurance, or having a new job where a medical is done. 80% people are not.
80% is a large number.
Is a large number.
So this is all preventive. That means it's
all
just
preventive.
protecting you.
And out of 80%, only 50% take the medication treatment. Out of 50%, only 30% have a regular medication. This is another point I want to tell you. See, you are on a diabetic medication or blood pressure or cholesterol medication. After 1 or 2 months of treatment, you find that your sugar values are okay.
Right.
Or your blood pressure values are within normal rate. Now, everybody has a blood pressure instrument at home or a glucose monitoring system at home.
Self-monitoring devices.
Self-monitoring, which we encourage.
Right.
So, and they feel that all these things, why should I take this medication? They stop it. So then when they come to us, and the things are again back to very high values. So we have to we train them that with the medicines we are controlling you.
Yes.
We are not curing most of the diseases.
Oh, there's a difference between controlling and curing.
We can cure certain things, like
Yes.
you got a stone in the gallbladder, kidney, you have got a small tumor or small swelling, that we can cure.
Yes.
You remove from the body, you cure it. But diabetes, blood pressure, high cholesterol, we can modify by lifestyle issues.
Okay, so
exercise,
but you can just manage them under a dangerous
and
level.
control them with medication. Yes, medication. If you are having 6 tablets, the doctor might make it 3 or 7, depending on your control of diabetes.
Right, modify it.
Yeah, but this is a very, very common mistake that people just abruptly stop the medication, thinking that my levels are okay. And I see patients once in a year, no medication. They feel and they feel all right.
Right.
The blood pressure does not give. 90% is asymptomatic. There's no symptom with high blood pressure.
Right.
The first symptom may be a heart attack or a stroke.
True.
So
straight away, you just go to the extreme.
Yes. We call it silent killer.
Silent killer.
So that's the very importance of routine, checkup once a year or even bi-yearly. There's no bad I would say bad family history.
Got it.
So I tell my patient that in addition to inheriting all the property of your parents and all, you are
Yeah.
likely to inherit
Inherit
some
their
of
diseases.
those
You
things.
brought out two important points. One is asymptomatic. That means I don't even have any overt manifestation of anything, and yet I go straight into a heart failure or a heart attack. And the second you said is the risk factors. And I think the third, more dangerous, which we are all prone to do, is going to Dr. Google, and there's so much information overload. So we take our test reports and try to interpret it and self-diagnose and self-treat. I think that's a very, you brought out a very harmful side of it.
Yeah, you see, like say on treatments, patient question, Doctor, I went on this particular drug. It has so many side effects. I said, all right, you Google aspirin,
Right.
vitamin B, aspirin
Right.
we give in heart attacks, we
Yes.
give for pain, we give for fever,
Yes.
so many things,
So many things.
arthritis, anything we give aspirin. So what do you mean? You got a heart attack or you got a arthritis? Nothing. So same way, all the drugs they are supposed to mention. This side effects may happen once in a million people,
Right.
but they are obliged to write down all the side effects. So your physician is best to tell you and to guide you. Well,
Right.
you can expect these side effects, and they will go away in a couple of days.
Okay.
Once you keep on taking medicine, if still they don't go away, then probably he'll change the medicine or something. So Google is not right to a large extent.
True.
It puts you in a lot of doubt.
True.
If you want to read Google, then just see the salient points and then discuss with doctor before you finally make an opinion of the disease or something.
This is a very important point.
Yeah.
So go back, the communication with the doctor
with the
and the
doctor.
interaction with the doctor is the final and the vital link.
Yeah.
The rest is just inputs. So that becomes important.
So we don't mind a little bit of Google language, that patient is aware of what's happening around and what his diagnosis is. And sometimes doctor also get irritated. Then you go and get treated from Google,
Yes, yes.
So we have to tell them that you have to, certain things are there which you can expect out of Google, but not everything.
Right. So the wisdom and the experience of the doctor is most important. And we hear about, along with preventive health, there's also talk about vaccinations. How can we protect and prevent any harm? Do they play a role, or it's only for children?
No. That's again a point. See, after certain preschool things, parents are very, very careful, taking to pediatrician, maintaining a card and everything. After 5 or 10 years of that childhood, they all forget. Adult vaccinations are forgotten.
Right.
So, but yeah, there are preventive vaccination, and there are 70 to 90% protective. See, no vaccination is 100% protective.
Right.
It depends on your immunity and the environment, how bad is your disease.
So there's a history along with that, which couples with the vaccine.
Vaccinations are important in adults, especially I would say the flu, influenza vaccine every year.
Right.
With the
and that's an annual one.
Annual one,
So
every start of the winter, which has no side effects and reasonable. I don't think it's very expensive. And all these vaccinations are more important for people who are diabetic, hypertensive, who have any autoimmune disease like rheumatoid arthritis, or cancer patients, or who have weak lungs like asthmatics and all.
So with other problems,
other comorbidities.
That's
these people are more prone. But they should I would say everybody should have all these vaccinations, like
take it.
Flu vaccine or the influenza vaccine, to be given even from children.
True.
Of course, to the elder people. Then we have pneumonia vaccine, which we recommend after 60 years of age, and then tetanus and diphtheria, which is to be taken once in 10 years. Now, another vaccine which is very important is Shingrix, or the shingles.
This is that the one because of the actors are promoting it, or just because it's just because of branding?
No. I see so many patients. See, this happens on one part of the body, like chickenpox. It's a chickenpox virus, and it happens on a nerve root. So it doesn't go to other side of the body.
I see. Okay.
And it's a very, very painful thing, and the effects can last for years together, not days, years. It's a very debilitating thing.
And we would brush it aside as an allergy or something.
Yeah, like that. The mosquito bite or something happened. People get operated, they have pain on the right side of abdomen, and the pain comes sometimes before the actual blisters come.
I see.
So the acute pain in the abdomen, and people get operated by mistake.
So it's wrong diagnosis.
So what I'm trying to say, no, this is not a commercial thing, which is good in a way. Awareness has reached here, and there are only 2 doses to be taken. They are valid for nearly 5 to 7 years.
Right.
So it's a good protection, although it's a bit expensive at the moment. But people who can afford it, they should have it.
Right. And you mentioned, like, I mean, you don't even realize you have it, but it hits you before you can diagnose it. And one hears a lot about such things happening, and early screening or early markers, especially for cancer or fatty liver, something which I have never drunk in my life, and I have a fatty liver. I don't understand why I have a fatty liver, or maybe even an autoimmune. Is there technology coming out with more and more early screening tests these days
Yeah, we're diagnosing
for early diagnosis?
more of things which are not even that serious also, like fatty liver, grade 1 fatty liver. I think 60-70% people have it. It can
That's a
be
high number.
yeah, high number.
And is it dangerous? I mean, does it
Yeah,
affect?
ultimately yes, because your normal liver cells are being replaced by fat.
Right, that's
So
what it means.
yeah,
Okay.
so it can be due to diabetic. Most of diabetics have fatty liver. People who are obese, who have high cholesterol level, wrong eating habits, no exercise, sedentary lifestyle. So all these factors contribute to fatty liver. So these are some of the markers which you accidentally find. Now gallstones.
Right.
Gallstones certainly you discover for a ultrasound for some reason or the other. I got a son who is 40-year-old. He's got multiple gallstones. We just got it done.
Oh.
I said, "You're 40."
And was he complaining? Was it
No,
symptomatic?
no,
Nothing, no
complaint.
symptoms.
My wife has got gallstone, no
Right,
symptom,
right, right,
asymptomatic.
right.
But if it is single stone, we can wait for some
Right.
time. Multiple gallstones can cause problems. They can go and obstruct on the bile duct, cause pancreatitis.
True.
So what I'm trying to say is that some of the investigations are helpful also, and some are frightening also. So if there's something asymptomatic, then your doctor or surgeon is the best person to decide.
Right.
So ultimately, these things can create problems.
So medical research on the early screenings is vital for early diagnosis, because I think it's common sense. Early diagnosis is early cures. I mean, and unless we refrain from self-diagnosis. That's of course the takeaway from it. So it's great. I mean, I know you have challenges. What challenges do you find among, when you treat with us? You mentioned family history, or do we hide things, or how do we not cope
See, now
as a doctor?
with the insurance coming in a big way, they tell doctor, please don't write even on your prescription that I'm diabetic. I have not disclosed. Don't write that I drink.
I thought that was only for children getting married, and they don't want to say that the girl had cancer because she won't get a husband otherwise.
See, because on my prescription I have columns saying smoking, drinking, exercise, then periods for ladies,
Right.
and allergies. The 5 columns are
Right.
there, which I take and
Okay.
ask them.
Clear. Huh?
So some of them say I have to submit this prescription
So don't mention it.
in the insurance, or when they are admitted. Even then
Oh my!
they tell
Then
us.
how does the doctor know?
No, see, we have to know,
You have to know it. You will know it.
and
Yes,
your test
yes,
will show up.
Yes.
That you are diabetic or something.
Yes.
So then that's a problem. I said then we can't take a compromise. Then there are medical legal issues.
Right.
If patient says no, but it is there, then we can't hide it.
Right. So then this would bring up conflicting opinions or conflicting diagnoses between doctors. I mean, you know why you did it, but when you show up in the screening test and your sugars are up, and then you have a different opinion, how do you manage multiple doctors for multiple diseases in one person?
See, then the role of a internist comes here. He has to be controlling. It happens very commonly. See, in a hospital practice, you got a sore throat, they will call a ENT specialist. You got something in the urine, you'll call a kidney specialist.
Yes. Everybody has their own angle.
And they come.
I call it tunnel vision.
Yes, tunnel vision. They come and see that particular point, write that, and get further investigation done.
Yes.
And then write medicines which already must have been there.
Yeah.
Some of them are
duplicated.
So
perhaps.
there was the role of the internal medicine comes. He has
see.
to see that there's no duplication and there's a coordination between various people.
So when everybody comes back to the physician, and he's the master of ceremonies, and he has to clear it out. That's how, because this happens a lot, and we get very confused and flustered as a caregiver as well. Does a caregiver play a role in this whole drama of diagnosis? Or how should we play our role? I mean, let me rephrase that in a positive manner.
No, it's very important. The caregiver is a primary role, say mainly seeing that the patient takes the medicine regularly and as advised, and all medicines should be checked. When you get from the pharmacy, it's not 100% that he'll give you the same medication what doctor wrote.
Oh, so
it may be different make, it's all right. Yeah. But the composition may not be same. We see it every day.
Okay.
So the caregiver has to make sure, tally the medicine with the prescription, make sure there's the right medicine. right time they are given to the patient, and patient doesn't throw them away or
Oh, so there's
which
cheating going on here.
yeah,
Yes. Okay.
doesn't throw them away or because of side effects or
Yes,
something,
yes, yes.
and doesn't take on
I used to see my father-in-law's pills are still on the table, although I
yeah.
gave him in the morning. It's still there at lunchtime. Yes, yes, I
So
noticed
this is
that.
a practical thing what we see every day.
True,
So
true.
make
So the
sure that
caregiver has to be
the
vigilant as
things
well.
are done, and any symptoms which are not settling down
Very
in a
important.
reasonable time, consult a doctor, consult the physician or the doctor, whoever is treating physician is. So caregiver important is, and on a first visit, I feel that a caregiver must go along with the patient.
Okay, so start the story
Start the
together.
story together.
Right, right.
See, many
And be
times,
consistent, because
yeah,
today my daughter-in-law, tomorrow my father-in-law, tomorrow my sister, and then again I have
yeah,
to start
one
from zero.
caregiver should go
Continuous.
uh,
Sutradhar
for
like.
routine, not
Okay.
for a routine thing, but
But a longer one,
some
longer
longer
illnesses.
illnesses.
Right.
It's always good to take them along.
So when you said persistent, if there's persistent symptoms, I think a caregiver or the person should persist and seek another opinion or another doctor, or find another, ask or request to understand,
No, no.
another line of treatment.
See, second opinion is always welcome. There's no harm in asking for a second opinion. The reasons could be
To the primary doctor, I mean.
yeah,
Yeah.
through the primary doctor. The reasons could be either delayed diagnosis, or if the treating physician doctor is not sure of the diagnosis, or third is that it's a wrong diagnosis.
Right.
So you can, the caregiver can interpret in any way.
Right.
So you can always say, doctor, would you mind
Because to me, I don't know the diagnosis, but I know that the symptoms are there. That's
yeah,
all I can know.
yeah, and the things are not working in the right
Yes,
line
yes.
after a certain point, and so he or she can definitely ask for a second opinion, and most of our doctors they don't mind.
Thank you. Thank you, doctor. You've given us so many wise points. My head is swimming beautifully. Thank you for clarifying the doubts as well. What 3 tips would you give us as patients, as families, as common people, to ensure to partner with you for correct and early diagnosis? Anything that comes to your mind, top 3 things, just to summarize.
Yeah, 3 things are: don't hide your symptoms, number one, and don't be preemptive on your illness. Don't delay your sickness too far.
Right. Don't hide and don't delay.
Yeah. And second thing is, confide fully in your doctor.
Tell all.
What
Okay.
if in case you don't want a family member around, but you can always excuse them and give a full
Full history.
symptoms on something you may not want to talk in front of the family member or a friend. So second is, and third is compliance. That's the most important.
That's the most
Whatever the treatment is, blood pressure, diabetes, please be strict to the treatment. Unless you have symptoms or your sugar goes too low or BP goes too low, yeah, sure, go back to the doctor and reduce your medication.
Right.
But compliance is very, very, very important.
Right. So compliance, and thank you for those 3 things. So Dr. Hazuri has given us several tips, and I think as patients we have equal responsibility to first spot the red flags of symptoms we think are casual but may be serious. We must ensure we take preventive health checkups. He made an alarming point of 80% diagnosis at that point, and I think that's a significant number why we should ensure that. Choose your laboratory wisely and comply with what the primary doctor does rather than self-detection and self-treatment. Thank you. I hope we've all gained from these valuable exchange. Thank you for watching. Keep looking out for more such episodes on doctor-patient conversations brought to you by Consortium of Healthcare Organizations and Patients for Patient Safety Foundation. I'm merely carrying the voice of patients to all of you. Thank you.
Thank you.
These doctor-patient conversations are brought to you by CAHO and Patients for Patient Safety Foundation. CAHO is the consortium of accredited healthcare organizations established to promote quality, patient safety, and accreditation. As healthcare providers, we wish to partner with patients and educate them about the common disease conditions, symptoms, so that they become empowered partners. Towards this, we have partnered with the Patients for Patient Safety Foundation to bring to you doctor-patient conversations.
Thank you, ma'am. Patients for Patient Safety Foundation, established, as you know, by CAHO, focuses on patients, families, caregivers, and lay people who are unaware that they can engage and provide equal partnership in healthcare outcomes. We do this by creating suitable, simple patient education material which highlights early symptoms for early detection, and better cures, including the risks and consequences if these are ignored. But there is hope because we also provide tips for actionable protection and preventing of all such harm. Towards this, we bring you this series of conversations which addresses doubts and fears that lay hidden in a patient's mind, but experts, doctors clarify these, providing well-timed information for self-engagement. We do hope you build this partnership with the healthcare providers, and remember, our health is our responsibility. Thank you, and keep watching these episodes.